In this video, we will cover cardiomyopathy. Cardiomyopathy is a group of diseases that directly affect myocardial structure or function and refers to electrical dysfunction or diseases of the heart muscle. Any disorder that affects the heart muscle is called a cardiomyopathy. Cardiomyopathy causes the heart to lose its ability to pump blood well. In some cases, the heart rhythm also becomes disturbed. This leads to arrhythmias, that is, irregular heartbeats. Cardiomyopathy is classified according to the structural and functional abnormalities of the heart muscle. They are dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive or constrictive cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy or dysplasia, and unclassified cardiomyopathy. A patient may have pathology representing more than one of these classifications, such as a patient with HCM developing dilation and symptoms of dilated cardiomyopathy. And also, cardiomyopathies are divided into two major groups based on predominant organ involvement or causes of cardiomyopathy. These are classified as primary or secondary. Primary cardiomyopathies have a genetic, non-genetic, mixed, or acute etiologies, which are focused primarily on the heart muscles. Primary cardiomyopathy refers to idiopathic conditions involving only the heart muscles, whereas in secondary cardiomyopathy, another disease process causes myocardial disease. Secondary cardiomyopathies have infiltrative, toxic, or inflammatory causes which show myocardial involvement secondary to the influence of a vast list of disease processes that include but are not limited to amyloidosis, Fabry disease, sarcoidosis, and scleroderma. These are just examples. Pathophysiology of all cardiomyopathies is a series of events that culminate in impaired cardiac output. Decreased stroke volume stimulates the sympathetic nervous system and the renin-angiotensin-aldosterone response, resulting in increased systemic vascular resistance and increased sodium and fluid retention, which places an increased workload on the heart. These alterations can lead to heart failure. Sodium is a major electrolyte involved with cardiomyopathy. Cardiomyopathy often leads to heart failure, which develops in part from fluid overload. Fluid overload is often associated with elevated sodium levels. This is the concept of all types of cardiomyopathies. Patients with cardiomyopathy may remain stable and without symptoms for many years. As the disease progresses, so do the symptoms also progresses. Frequently, dilated or restricted cardiomyopathy is first diagnosed when the patient presents with signs and symptoms of heart failure, such as dyspnea on exertion, fatigue. Patients with cardiomyopathy may also report paroxysmal nocturnal dyspnea, cough, and orthopnea, which may lead to misdiagnosis of bronchitis or pneumonia. Other symptoms include fluid retention, peripheral edema, and nausea, which are caused by poor perfusion of the gastrointestinal system. The patient also may experience chest pain, palpitations, dizziness, nausea, and syncope with exertion. However, with hypertrophic cardiomyopathy, cardiac arrest may be the initial manifestation in young people, including athletes. Regardless of type and cause, cardiomyopathy may lead to severe heart failure, lethal dysarrhythmias, and death. Each type has its own pathogenesis, clinical presentation, and treatment protocols. So we will cover each type of cardiomyopathy separately. First, we will see dilated cardiomyopathy. Dilated cardiomyopathy is the most common form of cardiomyopathy with an incidence of 5 to 8 cases per 100,000 people per year. It causes heart failure in 20 to 45% of cases. Dilated cardiomyopathy is a primary myocardial disorder with genetic or acute origins. The cavity of the heart is enlarged and stretched, compromising the heart's ability to pump normally and relax approximately. In dilated cardiomyopathy, it is difficult for the heart to pump normally. Dilated cardiomyopathy is classified into ischemic cardiomyopathy and non-ischemic cardiomyopathy. Ischemic cardiomyopathy is a term frequently used to describe as an enlarged heart caused by inadequate oxygen supply due to obstruction in coronary arteries or caused by coronary artery disease, which is usually accompanied by heart failure. The lack of oxygen interrupts both mechanical and electrical functions of the cells, decreases contractility, and causes dysarrhythmia. The scar formed from myocardial infarction, leads to systolic dysfunction. Causes of non-ischemic cardiomyopathy is idiopathic or unknown. 10 to 50% of cases are identified by genetic mutation. More than 75 conditions and diseases may cause dilated cardiomyopathy, including the use of cardiotoxic agents such as heavy alcohol, cocaine, doxorubicin. Doxorubicin is a chemotherapeutic medication. Mixed edema, persistent tachycardia, Chagas disease, chemical agents, coronary artery diseases, myocarditis, pregnancy, endocrine disorders such as thyroid diseases, infections such as HIV, viral infections such as influenza. It may be genetic. It may be caused by hypertension, metabolic problems, muscular dystrophy, valve diseases. These diseases can cause dilated cardiomyopathy. When the causative factor cannot be identified, the diagnosis is idiopathic dilated cardiomyopathy, which accounts for the largest subset of patients with dilated cardiomyopathy. Dilated cardiomyopathy is distinguished by significant dilation of the ventricles without simultaneous hypertrophy and systolic dysfunction. Dilation of the ventricles or enlargement of the ventricles occur, but there won't be any muscle wall thickness. The ventricles have elevated systolic and diastolic volumes but have decreased ejection fraction. Pathophysiology of dilated cardiomyopathy. Microscopic examination of the muscle tissue shows diminished contractile elements of the muscle fibers and diffuse necrosis of myocardial cells. The elements are actin and myosin filaments, which causes muscle contractions and movements. Dilated cardiomyopathy appears with diffuse inflammation and rapid degeneration of heart fibers. This results in ventricular dilation, impaired systolic function, atrial enlargement, and blood stasis in the left ventricle. Both the right and left ventricle dilate significantly, causing a decrease in the ability of the heart to pump blood efficiently to the body. The structural changes decrease the amount of blood ejected from the ventricle with the systole, and less blood is then able to enter the ventricle during diastole, increasing the amount of blood remaining in the ventricle after contraction. Blood remaining in the ventricles after contraction causes increased end diastolic pressure and eventually increases in ventricular, atrial, pulmonary pressure and systemic venous pressures. These increased pressures continue to diminish the ability of the heart to pump blood to the body, and the heart failure symptoms may occur after all compensatory mechanisms are exhausted. Altered valve function, usually regurgitation, can result from an enlarged stretched ventricle. Poor blood flow through the ventricle may also cause ventricular or atrial thrombi, which may embolize to other locations in the body. Ventricular dilation causes cardiomegaly and contractile dysfunction. In contrast to heart failure, the walls of the ventricle do not hypertrophy. Sudden cardiac death from dysarrhythmias is a leading cause of death in idiopathic dilated cardiomyopathy. Early diagnosis and treatment can prevent or delay significant symptoms and sudden death from dilated cardiomyopathy. The signs and symptoms of dilated cardiomyopathy may develop acutely after an infection or slowly over time. Symptoms can include decreased exercise capacity, fatigue, dyspnea at rest, paroxysmal nocturnal dyspnea, orthopnea. As the disease progresses, the patient may have a dry cough, palpitation, abdominal bloating, nausea, vomiting, and anorexia. Signs can include, that means what we can observe is an abnormal S3 and or S4 sound, dysarrhythmias, heart murmurs, pulmonary crackles, edema, weak peripheral pulses, pallor, hepatomegaly, jugular vein distension. Decreased blood flow through an enlarged heart promotes stasis and blood clot formation and may lead to systemic embolization. Now we will see diagnosis. Physical examination at early stages may reveal tachycardia and extra harsh sounds. Patient with dilated cardiomyopathy may have diastolic murmurs and systolic murmurs. With the disease progression, examination also reveals signs and symptoms of heart failure, such as crackles on pulmonary auscultation, jugular vein distension, pitting edema of dependent body parts and enlarged liver. Diagnosis of dilated cardiomyopathy is based on the patient's history and exclusion of other causes of heart failure. Echocardiography is usually the basis for diagnosing dilated cardiomyopathy. Ejection fraction may be less than 20%, has a 50% mortality rate within 1 year. The chest X-ray may show cardiomegaly with the signs of pulmonary venous hypertension and pleural effusion. The ECG may show tachycardia, bradycardia, and dysarrhythmias with conduction problems. Laboratory study may show increased B-type natriuretic peptide if heart failure is present. Heart catheterization evaluates the patient for coronary artery disease. An endomyocardial biopsy done at the time of the right-sided heart catheterization can identify any infectious organisms or other causes of diseases. Treatments of dilated cardiomyopathy. Several different types of drugs are available to manage heart failure. Nitrates, for example, nitroglycerin, antidiuretics, for example, furosemide, decreases preload. ACE inhibitors reduce afterload. Drugs with last letters pril, for example, benazepril, captopril, enalapril, are the examples of ACE inhibitors. Beta blockers, for example, metoprolol, and aldosterone antagonists, for example, spironolactone, control the neurohormonal stimulation that occurs in heart failure. Anticoagulation therapy reduces the risk for systemic embolization from clots that form in the heart chambers. Oral anticoagulants may be instituted to prevent thrombus and pulmonary embolus. Drug and nutrition therapy and cardiac rehabilitation may help lessen symptoms of heart failure and improve cardiac output and quality of life. Patients may be hospitalized for infusions of dobutamine or milrinone followed by aggressive diuresis. After treatment, many patients see an improvement in symptoms for several weeks. A patient with secondary dilated cardiomyopathy is treated for the underlying disease process. For example, teach the patient with alcohol-related dilated cardiomyopathy to abstain from alcohol. Unfortunately, dilated cardiomyopathy does not respond well to therapy. The patients have multiple episodes of heart failure. The patients may benefit from non-drug therapies. Mechanical circulatory support device, for example, LVAD, left ventricular assistive device, or biventricular assistive device may also be considered. A VAD allows the heart to rest and recover from acute heart failure or serves as a bridge to a heart transplant. Other options include cardiac resynchronization therapy and an implantable cardioverter defibrillator. A heart transplant may be considered in the patient with terminal or end-stage cardiomyopathy. A permanent implantable VAD, known as destination therapy, is an option for patients with advanced disease who are not candidates for a heart transplant. Currently, about 50% of heart transplants are done to treat cardiomyopathy. Heart transplant recipients have a good prognosis, but many patients with dilated cardiomyopathy die before receiving a heart. Interventions focus on controlling heart failure by enhancing heart contractility and decreasing preload and afterload. This is similar to how we manage chronic heart failure. Treatment guidelines are based on the specific stages of disease progression. Medical management is based on clinical guidelines for heart failure. Treatment of patients with class 4 or stage D heart failure is more palliative than curative. Patients with dilated cardiomyopathy are very ill and have a grave prognosis. Our respite nursing care is very critical. Observe for signs and symptoms of worsening heart failure, dysarrhythmias, embolus formation, and drug effectiveness. The goals of therapy are to keep the patient at an optimal level of functioning and out of the hospital. Always include caregivers when planning a patient's care. Encourage caregivers to learn cardiopulmonary resuscitation. Teach them when and how to assess emergency care. Home health and hospice nursing can provide the patient and caregiver with palliative care. This includes strategies to maximize and maintain functional status or end-of-life care to prepare for a peaceful death. Next type is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is a genetic disorder that causes asymmetric left ventricular hypertrophy without ventricular dilation. Dilated cardiomyopathy, hypertrophy was not there. Instead, ventricular dilation is present. In one form of the disease, the septum between the two ventricles become enlarged and blocks the blood flow from the left ventricle. This is called hypertrophic obstructive cardiomyopathy or asymmetrical septal hypertrophy. Hypertrophic cardiomyopathy occurs less often than dilated cardiomyopathy. It is more common in men than in women. It is usually diagnosed in young adults and most often in active athletic persons. Hypertrophic cardiomyopathy is the most common cause of sudden cardiac death in otherwise healthy young people. It accounts for 3% of deaths in young competitive athletes. Causes of hypertrophic cardiomyopathy. It may be caused by aortic stenosis. It can be genetic or may be due to hypertension. Now we will see the pathophysiology. Hypertrophic cardiomyopathy is primarily due to the abnormal thickening of the ventricular septum of the heart. The thickening of the heart muscle commonly occurs asymmetrically but may also occur symmetrically. That means septum and the ventricular free wall both become equally thickened. The ultrastructure of the heart is also disrupted by patches of myocardial fibrosis, disorganization of myocardial fibers, and abnormalities of the coronary microvasculature. The thickened heart muscle and ultrastructure disruption change the shape, size, and distensibility of the ventricular cavity and alter the normal thickness and functioning of the mitral valve. As a result, the heart's ability to relax and contract normally is impaired. The increased thickness of the heart muscle reduces the size of the ventricular cavities and causes the ventricles to take a longer time to relax after systole. Muscle stiffness impairs the filling of the ventricle with the blood during relaxation. During the first part of diastole, it is more difficult for the ventricles to fill with blood. The atrial contraction at the end of diastole becomes critical for ventricular filling and systolic contraction. Forceful contractions eject blood from the heart too rapidly, causing abnormal pressure gradients. Mechanical narrowing of the passage by which the blood leaves the heart also may occur, acutely obstructing blood flow to the body. Cardiac muscle cells normally lie parallel to and end to end with each other, but the hypertrophic cardiac muscle cells are disorganized, oblique, and perpendicular to each other, decreasing the effectiveness of the contractions and possibly increase the risk of dysarrhythmias such as ventricular tachycardia and ventricular fibrillation. In hypertrophic cardiomyopathy, the coronary arteriole walls are thickened, which decrease the internal diameter of the arterioles. The narrow arterioles restrict the blood supply to the myocardium, causing numerous small areas of ischemia and necrosis. The necrotic area of the myocardium ultimately fibrose and scar, further impeding ventricular contraction. The four main characteristics of hypertrophic cardiomyopathy are massive ventricular hypertrophy, rapid forceful contractions of the left ventricle, impaired relaxation, obstruction to aortic outflow. It is not present in all patients. Ventricular hypertrophy is associated with a thickened intraventricular septum and ventricular wall. The result is poor filling of the stiff ventricle. Decreased ventricular filling and obstruction to outflow decreases cardiac output, especially during exertion. Now we will see the clinical manifestation of hypertrophic cardiomyopathy. Some patients with hypertrophic cardiomyopathy may be asymptomatic. Others may have exertional dyspnea, fatigue, angina, and syncope. The most common symptom is dyspnea, caused by an elevated left ventricular diastolic pressure. Fatigue occurs because of the resulting decrease in cardiac output and in exercise-induced flow obstruction. Angina can be caused by the increased left ventricular mass or compression of the small coronary arteries by the hypertrophic ventricular myocardium. The patient may have syncope from obstruction to aortic outflow during increased activity. This results in decreased cardiac output and cerebrovascular circulation. Syncope also can be caused by dysarrhythmias such as supraventricular tachycardia, atrial fibrillation, ventricular tachycardia, and ventricular fibrillation. Now we will see how to diagnose the disease. Clinical findings may be unremarkable. On chest palpation, the apical impulse can be exaggerated and displaced to the left. Auscultation may reveal an S4 and a systolic murmur between the apex and the sternal border at the fourth intercostal space. ECG findings usually show ventricular hypertrophy, EST, T-wave abnormalities, prominent Q waves in the inferior or precordial leads, and dysarrhythmias. The echocardiogram is the main diagnostic tool used to confirm hypertrophic cardiomyopathy. It may show wall motion abnormalities and diastolic dysfunction. Heart catheterization and nuclear stress testing may help diagnose and guide the treatment of hypertrophic cardiomyopathy. Doppler echocardiography has been used for many years to detect hypertrophic cardiomyopathy and blood flow alterations. Tissue Doppler imaging has been useful in showing dysfunction of the myocardium despite preserved systolic function. Cardiovascular MRI also is useful. Genetic testing may help identify those at risk before there are clinical manifestations of the disease. Echocardiogram, 12-lead ECG, and the complete history and physical examinations are typically performed every 12 to 18 months from age 12 to 18 years. These screenings may extend to every 5 years from 18 to 70 years of age in susceptible individuals, that is, those with a family history of hypertrophic cardiomyopathy. Now we will see the management. The goals of care are to improve ventricular filling by reducing ventricular contractility and relieving left ventricular outflow obstruction. These can be achieved with beta adrenergic blockage, which reduces the force of the heart muscles contraction, diminish obstructive pressure gradients, and decrease oxygen requirements. 3 beta blockers have been shown to be effective in reducing mortality in patients with chronic heart failure. These include metoprolol, sustained release, bisoprolol, and carvedilol. Patients with hypertrophic cardiomyopathy should avoid dehydration and may need beta blockers to maintain cardiac output and minimize the risk of left ventricular outflow tract obstruction during systole. Next drug of choice is calcium channel blockers, which decrease heart rate and contractility and vasodilate, thereby providing symptom relief. Example is verapamil. Calcium channel blockers can worsen heart failure and are associated with increased risk of cardiovascular events. So, verapamil should be avoided in heart failure treatment because they depress myocardial function with increasing heart failure. Next drug of choice is anti-dysarrhythmic therapy. Digoxin is most commonly used to slow ventricular response in patients with heart failure, although beta blockers have been shown to be more effective than digoxin during exercise. Combination of beta blockers and digoxin are more effective than either drug alone. If contraindicated, amiodarone may be an alternative drug. Patients with hypertrophic cardiomyopathy may need to limit physical activity and avoid excessive weight gain to avoid a life-threatening dysarrhythmia. Amiodarone is the only drug shown to reduce the incidence of arrhythmogenic sudden cardiac death. Non-surgical septal reduction therapy, also called alcohol septal ablation, has been used to treat obstructive hypertrophic cardiomyopathy. This procedure is oftentimes indicated for patients with advanced age, patients with high operative risk, or those with a preference to avoid surgery. In the cardiac catheterization laboratory, a percutaneous catheter is positioned in one or more of the septal coronary arteries. Once the position is verified, 1 to 3 ml of 95 to 98% of ethanol is injected to destroy the myocardial cells. The procedure produces a septal myocardial infarction. The resulting scar is thinner than the living myocardium, so the obstruction is reduced. Pacemakers and automatic internal defibrillators may be implanted to treat severe bradycardias and lethal tachycardias. Patients at risk for sudden cardiac death need a cardioverter defibrillator. A pacemaker may be implanted to alter the electrical stimulation of the muscle and prevent the forceful hyperdynamic contractions that occur with hypertrophic cardiomyopathy. AV pacing is helpful for patients with hypertrophic cardiomyopathy and outflow obstruction. When the ventricles are praised from the apex of the right ventricle, septal depolarization occurs first. This allows the septum to move away from the left ventricular wall and reduces the degree of obstruction of the outflow tract. Atrioventricular and biventricular pacing have been used to decrease symptoms and obstruction of the left ventricular outflow tract. For some patients with DCM and HCM, that is dilated cardiomyopathy and hypertrophic cardiomyopathy, biventricular pacing, also known as cardiac resynchronization therapy or CRT, increases the ejection fraction and reverses some of the structural changes in the myocardium. Some patients with severe symptoms unresponsive to therapy may be a candidate for surgical treatment for their hypertrophic septum. A ventriculomyectomy and myectomy involve cutting into the thickened septal muscle and removing some of the ventricular muscle. Most patients have an improvement in symptoms and exercise tolerance after surgery. Interventions for hypertrophic cardiomyopathy focuses on relieving symptoms, observing for and preventing complications, and providing emotional support. Focus teaching on helping patients plan to avoid strenuous activity and dehydration. Any activity that causes an increase in systemic vascular resistance is dangerous. Rest and elevation of the feet to improve venous return to the heart can help manage chest pain. Vasodilators such as nitroglycerin may worsen the chest pain by decreasing venous return and further increasing obstruction of blood flow from the heart.